Hello, good afternoon. Welcome everyone to our 10th webinar. This is our next to last webinar. The last webinar will be just before the conference in the first week of November. But this is the last one where we'll have more or less scientific content. On the last one, we'll have some of the people from Portugal inviting you to come to Lisbon. So we're very excited today to have this webinar on data and digital public health, and we'll be looking forward to that. And also, we're very happy to be only a couple of weeks away from having you all here in Lisbon for the conference. So preparations are underway. So we'll be looking forward to host you all in the couple of weeks. I'd like to share with you, as we usually do, a video of Lisbon, also to somehow make sure that you come to the conference for the scientific purpose, but that you can also enjoy in the leisure times also the city and the surroundings, and there are some suggestions for you to enjoy. So I hope you like the video, just a couple of minutes of video. So as you can see, the city and the surroundings do have a lot to offer, and I hope you get to enjoy all of this as well while you're here. We'll trying to get good weather to welcome you in Lisbon, but of course it will be November, so one never knows. But still, I'm sure you'll enjoy the city quite a lot. Um, Lisbon is the European Innovation Capital this year, so it's also aligned with the topic or the main theme of the conference. So we're looking forward to share all that with you. And surely, data in digital public health is part of that innovation. So it is with great pleasure that I introduce to you Teresa Leão, who will be the moderator for today's session. Teresa, welcome to the session, and now the show is yours.
Thank you, Ricardo. Good evening to everyone. My name is Teresa Leão. I am a medical doctor, a public health specialist, and I've been working in the Faculty of Medicine from the University of Porto and also at the Institute of Public Health from this university. It is my great pleasure to moderate this webinar on data and digital public health. We will have 3 speakers and 3 presentations, short presentations, and hopefully full discussion on the importance of data and the use of digital means to try to improve public health, to measure and improve the health of the population. So we will have 3 speakers. We'll have Henrique Martins. Henrique Martins is one of the first chief medical information officers in Portugal. Actually, he is a medical doctor as a background. He was responsible for setting the agenda for e-health in Portugal. And he was the president of SPMS, the Portuguese Digital Health Agency. And currently he has been working as an academic at ISCTE and FCS-UBI in Portugal and at the Korean University Medicine as a visiting professor. He has been teaching and researching quite extensively in terms of digital health, healthcare systems and transformation, leadership and management education for medical students and other health professionals. He has been, of course, engaged in several consultancy projects, namely for the WHO, but he has been more recently the coordinator of the Expand DH project. The second speaker is Clive Tan. Clive is from Singapore, so from a bit far away from here, and I think it's about 1 a.m. Over there. Clive is a public health specialist. He has been working as Director of Medical Services for the Home Team at the Singaporean's Ministry of Home Affairs. He has been working, he has worked a lot during the COVID-19 pandemic in terms of managing outbreaks and trying to improve the response for the COVID control, and especially has been working in terms of controlling these outbreaks in the foreign worker dormitories in 2020. And due to his work has been awarded, recognized in terms of publicly and politically in Singapore. Clive teaches at the School of Public Health in the National University of Singapore and also at the Duke and EU's Center of Regulatory Excellence. And he has been quite important in terms of discussing the Health Information Bill in 2025 and also the latest version of the Digital Health Master Plan for Singapore. And finally, he works or has been involving in terms of health service and program planning, and he has a strong population approach, not only in terms of population-wide, but also focusing on the most vulnerable groups. The third speaker, coming back to Europe again, is Luc. Luc Nicolas is a social scientist. He has a background between political sciences and economy. He has been working for a long time with different organizations, and in the beginning he was focusing mostly on the operational side and also this link to public health, for example, with Doctors Without Borders, but also in the fight against HIV and AIDS. And since 2005, so for almost 20 years, he, as a e-health expert, he has been directly involved in the making of the different components needed to create and maintain the e-health infrastructure at the national, European, and international level. He is or has been supporting the Belgian Ministry of Health in developing a digital transformation roadmap in terms of the Belgium or national-wide. And he has been working in ETHEL, the European Health Telematics Association. So we'll start with the first presentation or the first sharing of knowledge from Henrique Martins. This is called, is entitled as Patient Data Source and the Data Target. And he also will mention a bit about future trends in the context of European health data space. Henrique, thank you for being with us. The floor is yours.
Thank you, Teresa. Thank you very much. I'm sorry I was not able to be super efficient in the sharing of my screen. I'll do it now.
No worries, you have time.
Everything will be fine. Yeah, it's my pleasure to be here. Just let me know if you can see my slides.
Yes, yes.
And really talk to this topic in preparation for our discussion. I'm very happy to join in this panel. And very quickly, what I want to convey could be summarized into 4 points. First, assume we can cover in such short time the main digital health challenges, and one of them being that we look at patients differently. And if we are to be serious about digital public health, we need to accept patients are becoming increasingly more digital. And then, as a sort of a summary, I would invite people to consider patients as a data source, patients as a data mover, and patients as a data target. And here I'm a little bit more helpful in my sentence, because I bracket two concepts that are not the same, but I think they have a lot of similarities. One, which is called digital therapeutics, DTX, which is quite the thing these days. It's growing rapidly, especially in Europe. For example, in Germany with the DIGA law and other countries reimbursing digital therapeutics through mobile apps and other ways of providing that. And then something which is different, as I say, but it is still targeted at the individual level, which is precision public health. And so very quickly, before we go into the details of digital health, it's important for us to understand that we all want healthcare systems that are equitable, safe, effective, patient-centered, timely, and efficient. And data, knowledge, technology in an aging population are the connecting dots for achieving these 6 aims that have been outlined many years ago. Now, digital inclusion, one important challenge. And when we think about digital public health and we consider that not all people have the same access to digital technology, this is one important factor. But also aspects such as telehealth or the usage of digital clinical services that are trustworthy. These are just some challenges, but one of the challenges that is perhaps the uniting challenge in all of these is how do we use and how can we maximize the usage of health data. Now, this requires an understanding of what health data is, and this is, of course, beyond the time that I have, but enough to say that anything can be relevant to health to some senses, and we learned that through the COVID pandemic. We learned that what I call in my European Parliament report on public health data and the European Health Data Center, and in those of you that are interested, there will be a link in the quiz. So I'm just hinting you that you should pay big attention to this slide if you are serious about the quiz later on. But you will see in those references this report, and where I talk about data of public health relevance. So data that may not be health data may become data of public health relevance, such as, for example, movement of citizens in a city, and this became important data. So Today, there is no boundary between structured and unstructured data, like this diagram represents, because with large language models, with AI, we can transform structured and unstructured data. Now, I mentioned to you that digital patients are key to understanding how we can use digital and data for public health, because patients are increasingly using more digital tools. So they become a data source. Patients have access, use increasingly their mobile phones, their wearables, bracelets, smartwatches, implantables, and so on. So they produce data. And these wearables are getting smaller and more biological, which means that increasingly we can produce data about ourselves and, of course, load that data into the health systems and contribute to a better understanding about ourselves. What does this move in practice? It means, what does this mean in practice? It means we should conceptualize around each human what I call a personal health data space. So in Europe now, we are living the early days of the European health data space. And in Article 8, it talks about the rights of users and the rights of access to their data. And I don't have the time. I just invite you to go and read this paper. It's online. But it's basically talking about this pyramid of usage from access, accumulation, curation, control, visualization, and living your everyday life through data-provided services. What does this mean? It means that, like in Waze, when you drive around the city, you use data to give you the best route. And actually, you use other people's data to help you decide your own route. So this is the concept of using data to create my avatar that, in a way, tells me how good I am today and what should I do to get better. Citizens are also data movers, and in Europe, this means more and more we are exchanging data across Europe. This is an old slide where you can see countries joining the so-called cross-border services, where citizens are entitled to transport their prescriptions and their patient summaries. And a very important concept is that this paradigm of data sharing across systems is moving to the patient being the mover of data. So more and more patients are being able to download data about themselves from hospitals and healthcare systems, and then upload that information into another healthcare system. They can also share to store. This concept means that I share and I give it, for example, I make a lab test in a private lab, I go to a public hospital, and I say, you know what? I want you to have my data because this will increase the chances of me getting better care and actually cheaper care because I avoid repeating the exams. Share to view, I want to share my data with someone. I want them to see my information. And what I call share to share with a chain there. For example, in Ishte, we're doing a very interesting project looking at blockchain as an enabler to secure and to give me visibility on that. Not enough time, but just to incentivize people to check the internet for this project. It's called XShare, and it's exactly about the capacity of all of us as citizens to pick data from different softwares, maybe a health portal from the Ministry of Health, from the hospital, and download or share with another person like we do with photos on our phones. So chase this and let's learn about this. And if you want to learn more about this type of projects, just hit this QR code or hit the link as you have access to the slides. How is Europe organizing itself around this? It is putting together what we could call a set of rules, a set of specifications, a set of guidance, in the medical terms, guidelines to programmers to develop systems in a way that they can talk to each other. We call this the European Exchange Format, and this over time will become compulsory across Europe. And then finally, patients as a target of treatment. So I invite you all to read about digital therapeutics, which is this idea of an evidence-based therapeutic intervention driven by software. And this can include prevention, but also management and treatment of a medical disorder. So it is a form of precision public health, where you intervene in someone, you intervene in the person by changing behaviors, by alerting him or her on what to do and what not to do. And this slide is very busy, don't worry. It's just to show you how many randomized clinical control trials there are already on these type of technologies. So this is not just an invention coming out of a startup company or two from around different countries. This is already robust, evidence-based tools. Many countries have already approval procedures to approve these digital therapeutic solutions. Finally, if you want to know more about the format and how Europe is organizing itself, you can access this through an online seminar that will happen on the 13th of November. And if you're really interested in these topics, there's also a bunch of papers that I wrote and links and some Spotify material. So, Teresa, I think I will stop sharing for now, and over to you.
Thank you, Enrique. So this was a first glimpse on the idea of having data being shared, stored, and used to improve health of the population. We'll now have two different perspectives, one from Singapore, another from Belgium. From Singapore, we'll have Clive, who will talk about the progress in precision public health, how it has been integrating health and social care data and services in order to tackle the determinants of health, the social determinants of health. Clive, thank you very much for being with us.
Thank you very much, Teresa, and thank you for the invitation. So I will start off my presentation. Thank you. So I'm Clive. I'm a public health physician based in Singapore. And I think in Singapore, we have been making good progress in terms of digital public health and also precision public health. So I kind of put up my key messages up front, right, to say that there is strong progress, and we're happy to share how the progress is like. We're starting to leverage on the health and social data we have to discover where are the areas of higher health need. The integration of health and social has been an ongoing challenge for us because it belongs to different ministries. But we've also worked to build 3 integrated health systems that will help us to do this better. So a short introduction about Singapore. This was a photo taken outside of my hospital. As you can see, this elderly couple is on the way back from the hospital to their homes. This scene is common, right? 2 elderly patients coming to the hospitals. You don't know who's the patient, right? Is it the man or the woman? But one of them is the caregiver. And the old age support ratio is dropping a lot. We have about our life expectancy is 84 years, and our per capita expenditure is 3,005. So our old age support ratio is at 3.8 right now. So it has been steadily dropping. So we do benefit from very high healthcare standards, which is why people can live up to 84 years old. But we've also found that the last 10 years of life are spent in poor health. So this is something that we are concerned about. So a quick glimpse of our health system design is that on the right-hand side, the service delivery is organized into 3 healthcare groups: the National Healthcare Group, Singapore Health Services, and the National University Health Systems. So they have a mix of hospitals and primary care clinics and community hospitals within their group, and that allows them to deliver strong integrated care. What has changed in the past few years was that in 2022, it was announced that each of these 3 zones will have a geographical catchment. And for the National Healthcare Group, we are in the center, and our catchment is 1.5 million residents. We have been given very clear roles to say that we are now the population health manager we have to be taking care of this 1.5 million people, even though we may not know all of them. Not all of them use our services currently. We also have to be a regional health manager where we work with community and social care partners to deliver integrated services. In addition, we still maintain and keep the role of service provider. That means we continue to run our acute hospitals, community hospitals, and primary care clinics. And more recently, we've also been moving into more community care and home visits. So this took us a long time, right? From moving from government-owned entities to corporatization to forming groups and then now forming regional health systems. And with that, we have arrived at this bottom right-hand corner, this Healthier SG logo, Healthier Singapore logo, which our Minister of Health, Minister Ong, announced in 2022. And I think it was groundbreaking because it took on a population health approach to health. But even before that, we already have a lot of digital health initiatives happening in Singapore. So we have actually national level patient-generated health data in Singapore through the National Steps Challenge that is organized by the Health Promotion Board. Health Promotion Board also partnered with Apple to bring on Lumi Health. So the population is actually very attuned and very comfortable with this collection of personal data, health data, your sleep patterns, your exercise patterns, and then sending it to the government, right? The Health Promotion Board then rewards people with points and rewards so that they can claim vouchers for the supermarkets. We have also invested in electronic health records early and have a connected health systems, which then allow us to feed information into these health portals, right? So we have two national health portals, Health Hub and Healthy 365, and this allow us to send information and allow patients to access information that is personal to them. So this gives us a lot of opportunities both in big data and small data. So the 5 key features of Healthier SG is that first, the importance of family doctor. The second one is that each family doctor will work with a patient to develop a health plan. The third one is to emphasize on the importance of community health partners. The fourth one is this enrollment plan where in the past, the patients are not fixed to a doctor, but we are trying to change that by encouraging patients to enroll with a doctor. This is voluntary. And the last one is around building the infrastructure, the health IT infrastructure and the data infrastructure. So that again brings us to the precision public health realm. So health and social data I mentioned are still under separate ministries. So we are in the progress of better linking them as we move forward. The good thing is that our integrated health systems, the clusters, are able to do a lot of that. So with a Healthier SG, IT enablement is a key pillar for Healthier SG. And we've also emphasized that we have two national digital front doors, Healthy 365 and Health Hub, that will allow patients to access their data and also for doctors to be able to direct interventions using those portals. We are also coming up with the Health Information Bill that will allow more transparent data sharing across the health sector and also allow us to collect better data from the private sector. Currently, the data is mandatory collection from the public sector. Private sector is voluntary, but once this health information bill comes on board next year, then gradually the private health sector also needs to contribute data. So just a glimpse of what we have developed so far is that we have been effectively using the data that we have to do geographical analysis of which are the zones that are at higher risk. So in our zone, we find that certain areas have older patients. Certain areas also have patients that have a higher rate of diseases. So when we look at diabetes prevalence, we notice that for Malay and Indian patients, the risk is higher. We also noted that for patients with, living in rental flats, they have a higher chance of getting readmissions when they come in with COPD and asthma. So this allows us to take on that precision health lens where we are able to give people more customized advice based on their personal risk profile. So with that, I think I'll stop here, and thank you very much for your time. Over.
Thank you, Clive. Thank you for your presentation. It was really, really interesting to see how Singapore is just making data collection being used for every single patient who goes into public hospitals, and how it can influence the data we have access to, as you shown in last slide. Now I would pass the floor to Luke. Luke will mention a bit or explore a little bit the SHARE project, SHARE in Public Health. He'll explain how he has been building or trying to help people building bridges between the clinical care and public health. And the context is the Belgian one, so it's closer to us. Luke, thank you. Merci for being with us.
Good evening, everybody. So I think you see my slides. And
yes.
Indeed, what I would like to do with you is I will come back to a few things that Enrique has already mentioned, but basically I would just like to tell you a story about two worlds which have been developing each in their silo, in their own environments, which need to communicate. And that will be my focus today, how to connect public health with clinical care when we speak with data, where data is now really the central focus in both domains. While in the past, maybe data was more important for public health than for clinicians, but today this is becoming essential for everybody. So we need to make the best out of it. And I'll try to provide a few insights on how to create those bridges. And I will give a number of examples, actually one from Belgium, one from another country, on a number of things which have been established already in order to build that bridge between clinical care and public health. And finally, I will give a few more information about the patient involvement that Enrique has already conceptualized quite well. So I'm indeed will be speaking a lot about the XShare project that Enrique mentioned. I just want here just to draw your attention to the fact that this project is very special because it's very unusual that in the same project you have, as you can see here, people representing the clinical value chain, the clinical research value chain, and population health together, who try to work in the same environment. The European health data space actually relies on three really important concepts. The one that Enrique mentioned, the fact that there is now a right accessing to the data by the citizen, by the patient, and to take control and facilitate the exchange of data. So that's the very, very first principle. But the second one is that those data can only be activated and thus used if there is a high level of interoperability between the data produced by the different systems. And finally, the third and most important one is that data should be reused in a way which is consistent, trustworthy, and efficient to support all kinds of finalities. So those three principles are important when we look at the incredible amount of data which are produced against an individual lifetime. So it's more than 1 million gigabytes. And And that encompasses a wide range of data. And today, more and more, the different technologies which are developing are trying to integrate all those data which are coming from different silos and different worlds, and to use them for the different finalities I just already mentioned. Accessing data is something, and it's important. It's not yet the case in many European countries, unfortunately, by the patient itself, but activating the data is still something else. It's really what will give the added value to those data. And for that, we need to rely, as I mentioned, on a number of structured and coded data. So the 6 domains that have been mentioned by European Hazard Space to create this new ecosystem are those 6 ones that you see on the screen. A patient summary, summarizing the key elements that you need to know about the patient, the hospital discharge report, the drugs dispensation and prescription, the lab report, and the imaging report. From those 6 information domains, there are a lot of things which will become possible if all over Europe we use as a reference the same format to describe them. And in each year we've been going a bit further. We've been trying to look at what the clinicians have decided was really important to have as a matter of data if you had no chance to meet the patient before. And we have been looking at what was required by clinical research as a matter of data to support a number of processes which were really important, like the patient selection and so on. And we have been just mapping all of that, and we've seen that basically 80% of the information available in the patient summary could fulfill the requirements for clinical research, but with a few possible additions which could support a number of additional business cases. So this is the first time we actually do this comparative analysis and try to combine. Now, what we have added, and that was mentioned by Ray K, is the yellow button, so which will give the possibility for each European citizen to activate those data. In other words, to share it for the finalities they will believe are relevant for them, just with a click of a button. So those interoperability format and the button, that are the 2 main weapons, if I can say so, to change the paradigm. Interoperability, we've been discussing that in the health domain since 20 years, and progress have been slow. They have been progress, but have been slow. We believe that now time is ripe to get this change of paradigm moving. And as you can see here, you need to work on the 4 levels altogether. With the HDS, the legal part of interoperability now is in good way. The organizational one is still very much dependent on what each healthcare organization is doing or not. But on semantic and technical aspects, we have now the possibility just to make this difference. And as you can see here, creating the link between primary use and secondary use of data, the first motivation came from the clinicians themselves, who were fed up, to be very straightforward, to see new requests coming from many different people, and having to duplicate data in multiple platforms or multiple finalities. So interoperability, that's also an economic and an ethical, I would say, requirements nowadays. And as you can see here, that what is going to change is that this is an example from the clinical research. Once the data have been provided with a sufficient level of details and quality, they can be reused without further process for many other purposes. That's the idea of write one, read many. And that brings us to also to stop considering only our business case, but also consider what public health needs, what population health needs, what clinical research needs, and so that all the different standardization initiatives need to speak together. So in the clinical domain, FHIR, in the clinical research, for example, CDISC, and in the real-world evidence, OHDSI, just to give an example. So in ICShare, we want to look at all the different registries, and the main one, how can they interact with the EHR-X file and benefit just from this only once strategy? How can this support real-time or near real-time monitoring and dashboards? So to monitor very important data. How can we have new data types of data analyzed, new capacity to involve actors, and new possibility for collaborations? We have a paradox and a high cost today. In Belgium, we have an army of 100,100 full-time equivalents, which are used by hospitals to provide coded discharge reports to public health service. That's mainly related to DRGs. But still, there is still a very high concern about the delay, the data quality, and the quality of feedback received, although it costs that amount of money. And coded data are not today used to support continuity of care. They're only used, they used to only to be used for public health and reimbursement issue. So I just give quickly two examples. In Belgium, it has been decided that there would be one way to reduce that, so that all data registers used for public health would be first described with a number of metadata, but that we would develop an application which would extract the data from the original system and only ask the supplementary data which were needed for each data set. And that has been implemented all over in all hospitals of Belgium. Today, we have also a number of monitoring systems, which a number of sentinel laboratories, for example. And once again, what is changing now, and instead of having ad hoc data collection, we are going to have a near real-time laboratory-based surveillance systems where data which will be collected on the flow and analyzed, providing this dashboard which will be updated all the time. And this, together with other sentinel systems also implemented with GPs, with hospitals and with nursing homes, will provide us and will allow us to have very, very detailed KPIs implemented for a number of priorities, as you can see. And that's that kind of dashboard which is already implemented in Belgium. And we have the same system actually in Denmark, quite surprising. So where the same kind of initiative has been taken. But here, what is really interesting is that the clinicians themselves have been supporting the initiative because they receive immediately a feedback, so a benchmarking for themselves, for their own patient, for their practice, and comparing their practice together with the one of the other practitioners in the country. And I just speed up to come back with the idea of how the patient can come on board with this concept of quaternary prevention, where today we actually also need to address other issues like the over-medicalization to excessive information, over-screening, over-diagnosis, over-treatment, and actually the limitation of medical intervention. And in order to document that, we absolutely need the contribution of the patients and populations. And that requires indeed that the patient can provide directly the necessary data. And the long COVID, for example, is probably a very good example where today clinicians are a bit at a loss to know exactly how can we consolidate knowledge, how can policymakers also take the right decisions in terms of resource allocation and so on, and development of adapted care pathway without the contribution of the citizens. So new interactions need to take place. And as you can see here, there is already, and with the share yellow button, we hope that it will go in this direction now, the capacity for the patient to be in contact with requests coming from public health analysts and clinical research analysts, where they can accept to share their data, provided themselves by their wearables or by the data provided by clinicians. So just to finish, this single interface that you see here, this yellow button, is aiming at becoming a key interface for trusted party, but also to create a real value out of the data which are produced by clinicians and the patient themselves. And I will stop here, and thank you very much for your attention.
Thank you, Luke. I invite everyone who is watching on YouTube and other platforms to submit their questions. You are free to do so, and I will pose to our speakers. While there are no questions appearing, maybe we could, exactly. Thank you, Ricardo, for helping there. So I have several questions, of course. My main area of interest is not digital health, so I don't know much about it. So I have many questions arising in my head. And probably my colleagues also will have several questions to be posed to you. I would start these questions by the collection of the data and storage of the data and having the data available, then to the different challenges we have in terms of intervening, whether in the patients or considering the patients, and also the use of this data for public health. So my first question is, when I was a student of Erasmus 15 years ago, I went into Paris, and the French hospitals in which I was doing the residency, one of the tasks they asked us was to go into the lab, pick the papers with the results from the patients, and with the results physically pressed in paper, go into the services, and there distributing to everyone. And that was something that really surprised me. It was something that in Portugal we already implemented more centrally. So it was something, okay, I'm in Paris and this is not as good as in Lisbon. And I imagine that there are different perspectives in different countries from Europe in terms of implementation of the digitalization of health data. And I would like to know from your perspective, probably more from Luke and Enrique, what are the main challenges that you feel while trying to harmonize the access or the storage of information, and also the access that patients may have to their own health information?
So thank you very much, Teresa. What we are finding out, which is not surprising, is that there's a very large heterogeneity, as you described. For example, in the Expand project, we have a dedicated work package looking at how different hospitals around Europe relate to the same set of required data for a certain service, being a lab result, being, for example, and I'm a big fan of this particular service, the hospital discharge report. So the typical document that in many countries doctors produce as a summary of what have been the care provided to the patient, and that is not restricted to inpatient stay. So you can produce a report of a patient that is followed in the outpatient clinic. And these reports, they vary so much across Europe, from free text to highly structured text, from countries that use SNOMED, which is a worldwide systematic nomenclature that has provided tremendous amount of help to people researching in the areas of clinical medicine, but even in public health, and into countries that are not even part of SNOMED, so they cannot use these terms because these are licensed terms. They are not open source. They are not open standards. Having said all of this, when we meet, for example, the European Society of Medical Oncology, when we have had meetings with the European Respiratory Society and others, such as European Public Health, we see that there is a will to converge. And often clinicians in many geographies say, if there was a model, if there is some sort of a template, we cannot do it tomorrow. We cannot suddenly produce that immediately, but we will progressively align towards that model. And I think this is the key issue about the format, and this is the key issue about starting to solve this problem, is that we have done this, for example, for diagnosis. Many years ago, WHO has produced lists of diagnoses, what we today call ICDs. They're not perfect. They're never updated. Whatever ICD is being used around the world is perhaps 10 years dated regarding modern diseases. Occasionally, we have to create a code like COVID because we had to, but we often have to wait. But the fact that these are stable nomenclatures creates the stability that is required to teach clinicians, in this case, doctors, nurses, and so on, to document in a better way. So, I mean, it's a very long discussion and a very long answer, but I would like to end with a positive note. I see more and more clinicians being ready to really document in a better way. And why is this so? Because they have come to realize that without good quality data at the source, they will not be able to produce good science. And now, we live in a world of real world evidence, real world data. People are willing to data mine their electronic health records. They're not happy just with some statistics. They want more details, and they want to mix phenotypical data with genotypical data, and they're ready for it. But they also know it's their call to introduce good quality data. So we see a lot of enthusiasm that maybe a few years ago there was a lot of reluctance from doctors to participate in these discussions. We now have many doctors participating, joining projects, willing to do. So I think that's one way to contribute to better quality data at the source.
Luc, do you want to add on this answer?
Yeah, very quickly, because I was a bit long in my presentation, but it is clear that what we need today is collaboration. Is collaboration between domain, and actually we need also for the clinicians to accept that they have also a societal role to play, basically. So when they produce data, they don't produce it only just for now, for treating this patient now, but also treating this patient through all his life, and to support all the others to do it, and to provide the knowledge for others to learn from it. And that's what needs to change. I think what is really changing is that now the focus being much more on prevention, and well, not only primary prevention, but secondary, tertiary, and I just also even mentioned quaternary prevention in my presentation, is making a big difference. It's beginning to make a big difference, because basically, in order to do that, the clinicians cannot work anymore together. We see changes in the clinical practice also, where people want to do different things. They want to have a private life also, next being to being a doctor. In order to do that, they need to share data. They need to share. So in Denmark, the people accept code and to structure the data and to fill registers, which are used because they also want to demonstrate to the employer, which is the state, that they're doing a good job. for example, because it's a system where there's no financial flows, so they can't prove it. So you see how data, there are many new drivers which are coming today, which will support a new collaboration pattern, and which, together with the interoperability that we need to support the system, will force everybody to do that. But I must say that in my experience, it was also very difficult to have public entities speaking together. They were also living in closed worlds. Public health institutes were doing a nice job, but on their own. The public medicinal products, for example, agency, they also hold their own focus. They were not seeing the role they could play in that, in providing the data, for example, that everybody would be using in the system. So we needed to create those dots and say, no, we can't act alone. We need to work in an integrated ecosystem and build on each other. So that's what is now being realized. And if we don't do that, that has a high cost.
It makes all sense. I have here a question from Anne from Singapore, and probably Clive will be the person that will be able to answer to Anne. And actually, it's a question that is linked to this. So she asks if there are opportunities for data to be transferred between acute and step-down care services, for example, from hospitals and nursing homes or rehabilitation centers. And the second question that is related to the first, what are the security measures that have been implemented to ensure that the data is kept confidential and protected, for example, from hackers? And about the third one, I'll just leave it right there because I want to link with another topic. Clive, probably you'll be able to answer to the first two and probably linking also to your knowledge about Europe.
Yep. Thanks, Teresa and Anne. So in Singapore, we had a bad cybersecurity incident in 2018, and we actually spent some time strengthening the cybersecurity measures before we embarked on the Health Information Bill. So I think at this point, we are a lot stronger than before in terms of cybersecurity. As I mentioned, the connection of health data and social data is an ongoing piece of work, but I feel like we are on the right track now. With the Health Information Bill coming on board, and with the 3 health systems taking care of integrated care, but also integrating the data so that they can, in Onwik's word, better sense right, where are the areas of higher needs, and also be precise in giving the digital interventions or advice to the specific patients. I think I'll stop here and let the rest also comment on this topic. Thank you.
Do you want to comment on Europe about the security of the data and how can we ensure that this data has been collected is not going to fall on the wrong hands or even being used? I saw a question coming up that was, will it be used by, for example, some governmental entities that may be, I don't know, harming people due to that, due to access to this kind of data? I think there are 2 questions here. One is it safe? Can it be accessed by someone from outside of the network? And the second is, how can we ensure that this data is not being used for wrongful reasons?
That's for me, Teresa, right?
You can start, yeah.
Okay, so very quickly. First of all, there's this concept of who can use the data. And it's not, this is not necessarily evident. Different societies have different interpretations, for example, of the pertinence or the value or even the legitimacy of, for example, a private company like a pharma company accessing large amounts of data from European citizens. So, and because of that unclarity and different societal interpretation, with some societies being a little bit more suspicious than others, and some societies benefiting more than others because they tax these companies, they benefit from tax from these companies, whereas others are more procuring from these companies. we have had to come up with definitions in a legal format. And this is what European Health Data Space in the areas of secondary use, so the use of data that has been anonymized and can be used at large quantities for both public health, but also for research and for advancing products and services. And that includes profit, a word that is often forbidden. It's a word, it's almost in Europe, particularly in Europe, the word profit is almost profane. And it's not, okay, it's not. And this is an issue. And why is this an issue? Because health data has tremendous value, not just to help save lives, like most clinicians like to say, but it actually has economic value. It can produce effectiveness gains that will reduce costs. So that is the first problem. The first problem is that what some people call illegitimate access, other people call legitimate access. And so clarifying that is an important thing. And that is, I think, has advanced tremendous with this regulation. And for example, there's no difference for the regulation eyes between a private hospital and a public hospital. And sometimes people ask, oh, but a private hospital might be owned by an insurance company. So what? That doesn't mean that just the fact that you own something doesn't mean you do everything with the data that happens there. The same would be true with the government, to answer your second question. So in that case, do governments use the public hospital data to discriminate the person? No, right? So why do people trust? Well, why do some people in some contexts trust more the private sector than the public sector? And that's your second question. So how can we prevent governments, that was the question, from misusing data and discriminating people? Whereas in other geographies, within the same continent, I'm not even talking about the world, in other countries, it's the exact opposite. We trust the government and the public sector, while we mistrust. So this is about trust building, and that talks to cybersecurity, yes, to some extent, because of course, if you build, and to conclude, if you build an agreement and a technical architecture that will support this agreement, who can access what, when, and how, but then this building, which is perfect and everyone agrees with it and it has its rules, is then hackable, so you can actually drill a hole and go through walls, then no point having the building. This is why cybersecurity is a key enabler of trust, but it doesn't produce trust. It just sustains it. If you don't have trust, you may have the best firewalls in the world, but you will not have the agreement. So it's about that. But anyway, again, we will stay here all day.
My question is, would or is the regulations, or are the regulations that exist in Europe able to, one, protect citizens, and then also to, well, not necessarily produce, but to maintain the trust that may exist? Or do we need to have better regulations nowadays? Look, you have been working this idea of linking different countries.
Frankly, I think that we have in Europe the GDPR regulation active since a few years, and that made already a big difference. Now, to be very frank, when I worked for the Federal Service Public Health in Belgium, one of my tasks was basically just to train people in hospital who would be responsible for data security. And basically, there was no specialist for that in the hospitals when I started. It was incredible, but that was true. So we forced them actually to select and employ a volunteer, I would say, with most of the time no computers. So we started from very low, let's be very clear. And so that explained why it took so much time for hospitals basically to consider working with others, with third parties, because they were not yet confident in what they had. But I think that That has changed. Now there is a real culture of security within organizations. And in many countries, the circle of trust, and that's really what counts, is that basically people trust people they know who can be trusted. That's the way you work. That's the way it works. So the circle of trust is building on people who are respected in their community for their competences, for their behaviors, for their actions, and so on. And if they sign for it, many will follow. So when you build a system, when you share sensitive data, which are regulated highly and well regulated by the GDPR and now another of other acts in Europe, and you accept other systems to join, you have indeed a very solid foundation for sharing data and agreeing on finalities. It can be a bit long to create that circle of trust, but once that's established, this is really important. And we now see new actors coming. Before, around the table, you had only hospitals, you had EHR systems, and now we see new actors which are really important, which are, for example, the PHR developers. So the people who develop systems which are really focused on citizens. So the data, the citizens collect their data, can add different apps which support them in their disease, but also can, as I had explained in my presentation, can be exposed to third parties' requests, like public health analysts, for example, and participate into surveys and so on. So, and in order for them to do that, they need to abide to the same rules than the others in terms of security and privacy. So it's a very difficult task, but that's a very good way to ensure that. And for example, I just finished with that. The way that our health systems are built make a big difference. In Bismarckian systems like Belgium, Germany, or France, you have insurance systems, and people are very much afraid that their data are used to discriminate them. So that was one of the big fears. And actually, after 10 years now, people feel confident about it. But it obliged us from the very start to have very strict rules in terms of control of data by the patient and very transparent ones. In Scandinavia, for example, there is no real financial flows. And so that issue is not there. So the people are extremely okay with the principles of sharing data. They trust that basically if they are shared with public entities, for example, that's to improve public good. So there is a very different culture, and what you need to do, it's not only tactical, as I explained, is creating trust and relying on the right people to do it.
Let me just link the trust and having access to individual health records or data, and use the example of COVID. So during COVID, many apps were created for contact tracing, and there were different experiences in different countries related to these. And in some countries, they were highly costly but not effective. In others, they were a bit more effective. So is trust the main ingredient here, or were there any kind of lapses or immature acts that could have been prevented in order to make them more efficient? And maybe we could start with Clive, because I think in Singapore there was an app for contact tracing for COVID, right?
Yes. So in Singapore during COVID, we had to jump in, right, and collect data using Bluetooth devices. And at that time, it was a crisis. So everybody allowed the data to be collected. But I think what happened at that time was that it let people know that, hey, actually data collection at this big scale can work, right? After COVID, the government did delete all the data related to contact tracing as a way to build trust, right? That means we asked for this for the emergency. After the emergency, we will delete it. So that actually helped to build trust within the between the people and the government. Now that we're asking the people to give us more healthcare data, we need to, like Onwik mentioned, we need to build a very strong set of trust before we can progress to that stage.
That's a very good point. I have here a question from Robert Heck. Thank you, Robert, for submitting it. So he asks, what challenges do you see in enabling cross-country collaboration in healthcare data sharing? He's interested in knowing how to balance data protection, data sharing, especially in ensuring patient rights and safety. I think that we have already answered to part of the question related to the regulations we have in Europe. But Luc, do you have any further detail to share with Robert?
I think that the first step was to establish this right for the patient to have access to the data. So this is now done in DHDS. But I would say that it's not only because you give that right that it takes place. You can still play with that for a long time. In Belgium, that was supposed to be there since 2016, but it's only since last year that I'm sure that all the data which are produced and in relationship with me are accessible, because each hospital had to decide what they would accept to share and not to share before. And if you don't have a very strict and clear vision on that, it can take a lot of time. So you could have access to only some documents or living. So it has to be very clear. In terms of security, I think we need a high level of granularity in terms of control. I think that the capacity, for example, for a patient to decide to have a control not only on who has access, but sometimes to which part of the document. Sometimes people or designated third parties could have access to, is really important. So, and also having a capacity to monitor who has been accessing the data. For you to do are all really, for me, key functionalities, which I hope will be implemented all over Europe. And especially now in my health at EU, the monitoring, for example, is the capacity to see who has been logging in the system and so on, was from the very beginning described as a key functionality. There are also very strict requirements in terms of identification and authentication. And here again, there are a number of new initiatives being taken at the European level, which should still give more certainty and more insurance to those processes. So we see now several building blocks which were missing, which are coming together. Which, in my opinion, should solve the remaining challenges. Don't know if Enrique, you want just to add anything on that?
Yeah, I mean, quick addition, because the question also looked at cross-border and cross-country, and you mentioned that very important elements inside the country. I guess there's two things. One is that many countries still struggle with inside country sharing, and this is something that many people find it awkward, but countries are a mix of countries and regions and different health systems. So there's not that much homogeneity even within a country. And then on top of that, you should add two levels of complexity. One is language, which is a significant barrier. Of course, much has been improved with common terminologies, as well as now automatic translation and AI-based translations, but still it is a barrier. And then the other one is trust between countries. So sometimes professionals between themselves, they would share, and even the patient would share with a doctor of another country, but countries between themselves sometimes do not trust each other. When you go out of the EU, the treaties, the legal footprint between countries is drastically reduced. The same happens between US states and Canada, or US states and another country. So the US has a common language, which helps them a lot. We do not even have a common language. So it is a very interesting set. This is why, for example, I urge people to always go to Asia, where the way countries, and this is to provoke Clive to comment on this one as well, is when we, and both of us was in another life working with how can countries within Asia collaborate on data sharing. And there's other steps before that on trust building and even common interests. There might not be common interests, economical and sociological, or they might be, but there's no tradition. I mean, we have shared, banana sizes, and we have shared coins for years and years and years. We have a monetary union 20 years before we have a health data union, which maybe we can talk about a health data union in maybe 2030, when the full length of the regulation of the European health data space is starting to be implemented, full length. Some articles have a delay of 5 years. So 30 years of difference between common coin and common and common electronic record. You see, now you go and you want to share data between, for example, Morocco and Portugal, very nearby, but we don't have a common coin, and it's not in the nearest plans. So, however, to conclude, WHO, public health people actually, are leading the way in areas like World Vaccination Passport and common standards for sharing information on public health. Why? Because public health people know there is no borders. There's no borders for health. The bugs go around, the diseases go around, and health data needs to go around, even if the countries don't trust each other, and even if they are at war with each other. The diseases and the health data sharing is still necessary. Maybe Clive, you want to add something on this one, because you've been trying hard to bring some data from Singapore over to the EU and some knowledge from Singapore to the EU and things like that. Over to you.
We need to be quick. Sorry, Clive, but please share your perspective.
No, thanks, Henri. I think we've been looking at the European developments with a lot of interest. But I think to your point, yes, in Southeast Asia and in other parts of Asia, we do ask fundamental questions like, what is the purpose of data sharing? What is the economic purpose? Does it help the patients? And sometimes the answer is no, and then we kind of pause there. And yes, I as a public health physician, I want it to become more prevalent, but there is a time and space in the political space that we need to catch. Thanks.
Exactly. So just to wrap up this first discussion on this topic in the European Public Health Conference. I'm sure that this discussion will continue in November, so please join us and just catch the speakers and discuss with them in the corridors of the Public Health Conference. So I would say that it was quite clear the importance of having this kind of harmonized systems that work together in order to stop the fragmentation and redundance of recording, even overprescribing, even putting people in danger actually with excessive medication or over treatment or over analysis, etc., etc. And the importance to build trust and the need to have some patience in terms of building trust because we need it. And the importance of having this being done in collaboration, and the importance that people, health professionals understand the importance to feed these kind of systems, even for people to understand the importance of this, but also to trust on the regulations that do exist. And as Clive was saying, to understand what is the purpose. So knowing what do we want as public health services, professionals, what do we want with this kind of systems? We did not dig into precision public health due to the time constraints we have. But I'm sure that this discussion will appear in the future. And I think it's really need to think about precision public health. Who is being left outside? Who is being brought into the information we have? So this was a great discussion. Many thanks, Luke, Clive, and Enrique, for being with us at this hour. And Ricardo, over to you.
Thank you so much for such an interesting discussion. I think we could go on for a long time discussing the specific aspects that were raised, and also several of the questions that our viewers were also posing. So thank you so much to all four of you, for the three speakers, and also for Teresa to moderate. And this will surely also be a topic that will be addressed in Lisbon at the conference. This is an issue that is ongoing, and surely there's a lot to add still. So once again, thank you so much to all of you, and also for those that are watching. And now it's time for the quiz. I also invite Luke, Clive, and Enrique to stay put. They've created some of the questions, so I guess they'll be curious as well to see whether people will answer them easily. Yeah, so basically we usually thank you so much to the four of you. We will be using a platform that's easier if you use a mobile phone to answer the questions. You can either use this QR code to log in, or use the link that's here, ahaslides.com/EPHC Lisbon. So this is the platform that we'll be using. As I mentioned before, it's easier if you use a mobile to answer the question. It should be faster. And I also like to highlight there's a delay between what you'll be seeing on the stream and what will be the actual time to answer on your mobile device. So bear that in mind to make sure that you are aware of that difference. So we're waiting for people to log on so we can start the quiz. So everybody is welcome to participate. I highlight this is the last quiz we'll have for the sake of having winning an entrance to the conference. It will be something that is relevant for you to know that there's and I'll show you top 10 results of the people that have participated in the quizzes so far, and we'll announce the final winner on the next session in just before the meeting here in Lisbon. So I already allowed for some time for people to register, so we should start. So these are the current top 10 standings. So we have Francisco in first place with 5,797 points, and Elder in second with 4,747 points. So in a way, there's still a possibility for Elder to overtake Francisco in winning the free entrance to the conference. But it's going to be tight. Let's see how it goes. And then we have the other participants, which are a bit further away, and the experience tells us it's difficult to get more than 1,000 points in a single quiz. But it depends on how fast you are. So let's see what happens. And today's winner of the quiz will win a seat at the dinner and dance, and we'll also have a lottery at the end for another seat at the dinner and dance. So stay put. So we'll be moving towards the questions. So we already have some of the participants here. So let's see how it goes. So good luck to all the participants. Bear in mind that to take advantage of the prize, especially the dinner, you need to be registered for the conference. So Keep that in mind. So let's start the quiz. So the first question is, which of these information domains has not been prioritized by the EHDS regulation? Is it the hospital discharge report, the drugs dispensation report, the nursing report, imaging report, or the lab report? Okay, let's see the answers. So actually only one correct answer. It's nursing report. So let's see who actually got the answer right. And it was Diogo. So Diogo is now in front of the questionnaire of the quiz. Let's see the second question. From which countries were examples of only once best practice shortly described? Was it from Spain, from Belgium, France, Sweden, or Denmark? Two countries. Okay, let's see the answers. And the correct answer was Belgium and Denmark. So we had 3 correct answers on each one of them. Let's see who got most points. So there's still Diogo in front, Maria Manuel in second, and Elder in third. Next question. Interoperability needs to be dealt with at 4 different levels known as LOST, the different letters. I would say this one is just a matter of being really fast. This was the correct order, so connecting the different letters. There were 3 people who answered correctly. Let's see how that impacts the result. So Diogo is answered 3 times straight correctly, so he's leading, Elder in second, and Ze in third. Let's see the next question. Which of these is not a role of Singapore's regional healthcare cluster? Population health manager, regional health manager, health service provider, or health insurance provider? Let's see the answers. So the correct one was health insurance provider. So only one correct answer. So let's see who got it right. Who got it right, and he's increasing his leadership in the questionnaire. Let's see the next question. In Singapore, which is the agency that organized the National STEPS Challenge program? The Ministry of Health, is it the National Healthcare Group, the Health Promotion Board, or SP? Okay, let's see the answers. So, only one correct answer and 7 wrong ones. Let's see. So Negar had the correct answer and she leaps into third place. Let's see the next question. Healthy 365 and Health Hub are online platforms and tools that offer patients easy, direct access to various health services from the comfort of their own devices. What is the common term used for this form of technology? Is it digital front door, data lake, digital twin, or business continuity plan? Okay. 5 correct answers. Digital front door. Let's see the results. So Elder is leading, Jose is now in second, Maria Manuel in third. Let's see the next question. Well, already halfway through. Why should we use the health and social data we have to discover and prioritize areas of higher health needs? Is it because we want to better plan services to address health inequalities, address areas of great need, ensure healthcare providers focus only on high communities as they are easier to serve, to reduce healthcare costs by providing less care to areas with greater needs, or to focus only on improving patient satisfaction scores? It took me a while to read, so hopefully you had time to answer. And yes, most of you did answer correctly. So let's see who were the fast ones. Okay, so Diogo is still leading, Jose is in second, and we have Maria Manuel in third place still. So the first three are more or less steady now. Eighth question. Which data type is less commonly considered and holds the biggest unexplored potential in European public health? Data on communicable disease, data on non-communicable disease, data on the health system, or this odd answer, which is Nicholas. Okay. I guess we have a mistake here. We'll see how we sort it out. But indeed, it was a mistake, surely, from the question, eventually from the editing. But I understand none of the first place players actually was neither harmed or benefited from it. So let's see the next question. Question number 9. What best sentence describes the difference between a wearable and an implantable? A computing device that is always near to the patient or individual. An implantable is a computing device that is inside the patient or individual. Implantable collects better data than a wearable, and the wearable is safer than an implantable. Okay, yes. An implantable is a computing device that is inside the patient or the individual. Let's see who managed to answer mostly correctly. So Valentina is now in third place, with Diogo still leading and Jose in second. 10th question. Which is not a new paradigm of patient usage of his data? Is it share to score, share to view, share to share, or share to block? Okay, let's see the answers. It's shared to block. I mentioned it is not a new paradigm. So only one correct answer, and that was Diogo. Okay, so the positions are the same. 11th question, so only 2 to go. Why is digital therapeutics relevant for public health? Is it because there is RCT evidence that shows value in digital therapeutics? Is it because digital therapeutics models can inspire precision public health intervention? There is loose regulation, so action of public health doctors is essential, or because public health in the future can trust that digital therapeutics will always be safe because it is data intensive. Sorry. Yes, it's because they can inspire precision public health interventions. And the answers were drum roll. So Diogo is still leading, Jose in second, Duarte in third. Let's see the final question. Lisbon is known for its vibrant street art scene. Which Portuguese street artist gained international recognition for his distinctive works, often featuring large-scale murals and explosives as part of his artistic process? Was it Bordalo II, aka Corleone, Mills, or Ad Fuel? And the answer is Vils. So these are all street artists very well known in Portugal, but indeed the one using explosives is usually Vils. So let's see the final result of the quiz. So Diogo has won the quiz. So congratulations, Diogo, on winning a seat at the dinner. We hope you are already registered for the conference. And now we'll have the lottery for the gala dinner in Lisbon. And if Diogo is the one drafted, we will need to redraft because he already won the seat at the dinner. It's non-transferable. So let's see who wins the seat at the gala dinner. Okay. Maria Manuel has been the winner for the gala dinner seat. Congratulations on winning. Thank you so much. And last but not least, we would like to ask you to write down what word you would use to describe this webinar. So people are typing. I'll now also take the chance to thank you all for participating on this last quiz. We will now sum the points that were won today to the tally and see who was in fact the winner. We know from the results that Francisco was the winner, since it was not the second place that reached 1,000 points. It would allow to overtake Francisco. So I'd like to congratulate Francisco also on winning a free registration for the conference. Well, people are still typing. So apparently we don't have yet here the word that they would use to describe the webinar. But I would like to thank everyone for watching. We'll be looking forward to the last webinar, which will take place, as I mentioned before, in the first week of November. And until then, you can look up the previous webinars on the website of the conference. Thank you all. Thank you again to all our speakers, to our sponsor as well, Sanofi. And we'll be looking forward to seeing you all soon. All the best.